I'll start by saying thank you very much, everyone, for joining today. This is our bi-monthly AI for Women's Health event, organized by the brilliant team of Emma, Christine, Annalisa, and myself. Uh, and some interesting news. We have been affiliated with the Alan Turing Institute until now. And we are very pleased to announce that we are also now joining the Teesside University, thanks to Annalisa. Thank you so much, Annalisa. Um, and so let me introduce you to our first speaker. We have two talks today. The first one being Ankita. So we'd like to just apologize because we had a last minute change of plan. Jane Hist was not able to join us today, but very kindly Ankita is offering to introduce us to their teamwork. So I'll introduce Ankita first and then hand over to you, Ankita. So Ankita is a DPhil scholar at the Nuffield Department of Women's and Reproductive Health at the University of Oxford. She has 15 years of experience in medical ultrasound imaging, with a clinical background as a consultant sonographer, leading 11 ultrasound clinics across London. Ankita is part of the Global Women's Health Group, led by Prof. Jane Hist from the George Institute of Global Health. Her work centers on the human-centered design of Smart Health GPT, a ChatGPT-4 powered chatbot developed for community health workers in rural India. And today, Ankita is going to talk about designing an AI intervention for frontline maternal health workers in India. So I'll hand over to you, Ankita.
Thank you, Bianca, for that lovely introduction. Let me share my screen with everyone, and then I can start talking a little bit about our work. Please let me know when the slideshow is visible.
Yes, perfect. Thank you.
Okay, great. So I know Jane wasn't able to join today, but the work that I'm presenting is the same work that our team has been working on. So hopefully you'll get a little bit of an introduction to what our team is doing. There are several projects within the team itself. This has been the star of the show. This is related to designing an AI intervention for frontline maternal health workers that are called ASHAs in India. So I'll give you a little bit of the background here. So Smart Health Pregnancy Program is it's a trial that Professor Jane Hurst has been leading. It's led across different countries, but within India itself, it was conducted in two states, in Telangana and Haryana. And this is essentially a tablet-based system that helps improve guideline-based screening. And it focuses on three conditions related to maternal health, which is anemia, gestational diabetes, and hypertension that could be acquired during pregnancy or even in the first year after birth. So these community health workers, as you can see in this picture, they are given this tablet with this particular software, and they are going and screening women, and this helps them have a system of clinical decision support right in their hands. So this is a trial that's already been ongoing. I'm not going to talk too much about this itself because this is where the background of the work is, but there's many, many different components within the Smart Health Pregnancy Program, and I think that's what I want this slide to show you. And there's an education program where these community health workers are given in-class education about these different high-risk conditions. There's also clinical decision support application and an application for the PhD doctors as well. But when we started looking at this system itself, we realized where we wanted to focus was the capacity building of these frontline health workers. So this is where our case study, which we call Smart Health GPT, comes from. And we've got a big team that has worked on this. We've got their names here, and I'll introduce them again at the end. So now that you have a little bit of background context, let me start with a little story. So this is the story of Sunita. She is an ASHA worker. The word ASHA stands for Accredited Social Health Activist. She's a mom. She's 42 years old. She's in a rural village in India. She's not super educated. She's educated up to grade 10. She has to walk on foot every day for 5 to 6 hours in the hot climate of India. And she is in charge of covering a population of 1,000. Within her village, she's considered like the older sister of the mom or the village. So she's got a lot of duties within maternal health. So she has a register where she'll record the LMP, the last menstrual date of every woman that she knows in her area. She's the first one to know when someone's getting married, when they've missed a period. Sometimes she knows that a woman's pregnant before even the woman in her village knows. So she has a very close, intimate relationship with all of these women. But one of her jobs is really when she does these field visits is to know when she needs to refer a woman to a high risk center, which is the usually ends up being the primary health care center. So one day she's conducting her visit, and a woman in her village says, "Is it normal for me to have a headache during my pregnancy?" So Sunita has the smart health pregnancy system. She might be able to, deal with some basic clinical decision support, but this is a question that she might not be prepared for because she knows this woman personally. She's had several miscarriages. She might be older and high risk herself. So Sunita does what I personally saw many ASHA workers do. She goes on a WhatsApp group where she's got a lot of other ASHA workers and she asks them, what should I do in this case? This is something we actually noticed is happening. Even though they've got a tablet device, they're getting asked these maternal health questions that are very simple, but sometimes they need that extra support. And we realize that there's a gap, that currently there is no standardized guideline base for these ASHA workers to help them address common everyday maternal health questions. And evidence-based information is very difficult for them to access. It comes in these PDF forms that they've got to access online or they have to read through different books. There's nothing that tells them right there and then what is the actual answer they should give. And on the other side, you'll see a little quote from a doctor in Haryana, where Asha's like Sunita work. There's a lot of pressure placed on healthcare workers like Sunita. This particular doctor said, there's a lot of myths about the patient, about diet post-delivery, and they don't even counsel the patients about it. So there's almost this impression that perhaps the ASHA workers are not counseling the women at the standard that they should. Women are not getting the right advice about pregnancy at the right time. So what we decided to do is we decided to add a little component to the Smart Health pregnancy application that we call Smart Health GPT. This is a time where ChatGPT was getting quite popular in 2023. But the concern was safety. So what we decided to do was say it's not going to go to ChatGPT, which is the internet-based ChatGPT. This is going to be a guideline-based chatbot. And this is going to respond to the frequently asked questions that Ashas like Sunita are getting in the field. And we will use something called Retrieval Augmented Generation, or RAG, which means the responses are only going to come from the corpora of maternal health guidelines that we feed in the system. If the chatbot doesn't know the answer, it's not going to hallucinate. It will say, I do not know the answer. And we had a back-end a technical team, very qualified, very experienced, working on this to support the development of this chatbot, which was really helpful. The responses would be given to the Ashas in their own language in a way that they can understand. This whole project was funded by the Bill and Melinda Gates Foundation. This is our original grant that we got. So originally this was meant to be like a quick 3-month project, which then got extended and then got extended again. So we were quite lucky that we got some time to work on this. Originally, we were thinking that we would just create a knowledge base, an encyclopedia, and a text-to-text based chatbot. But as I'll explain, this was an iterative process and it ended up evolving and became something much bigger than what we had expected, which was absolutely great. So this was our solution. This is what it looked like for the ASHA worker. So you saw a little glimpse of the tablet that the healthcare worker would have. So this is the existing Smart Health pregnancy system. And if you see on the top right, we just put this little icon, and this icon would be there on any screen. So at any time during the consultation, if the Asha gets a little question like, can I eat papaya during pregnancy, for instance, she can just click on this little button. This pops up. This is obviously in English, but this can change to her own language, which would be Telugu or Hindi. And she enters the question and gets a response. And just to sort of demonstrate how the chat GPT at that time would be slightly different than SmartTel GPT. So chat GPT might give a good response. And in this case, you can see it's a very long response. But SmartTel GPT gave very straightforward responses. But the biggest difference here is on the bottom here. It says page 64 from the National Guidelines of Diagnosis and Management of Gestational Diabetes, which would be the Indian guidelines. So this is something which was very different, is that we were on the back end able to see the source of the information, see where it's coming from, rather than just, any guideline from anywhere in the world. This was very applicable to their context. So I will probably not have the time to go through all of the different phases today, but I plan to broadly introduce the overview of the work. And then at the end, I will invite the audience to ask any questions because there's a lot more than I'm going to present today. But the broader project was divided into 3 phases. First was a needs analysis, where we wanted to understand, is there an actual need to bring AI into the system, and what is the actual need on the ground that we're going to take care of? Then the second phase was clinical validation to ensure that if we are using REG, is the answer actually safe? Is it coming from the guidelines? And then once we know that it's safe and it is addressing a need, then we do a very early user evaluation of the prototype itself. So during the needs analysis, we took a bottom-up participatory approach. And this was very important for us to make sure that if we are giving anything to these ASHA workers, they are involved in the co-design process. It was a little bit challenging because they had not been involved in designing an AI-based intervention before, so we had to take baby steps. So we started with trying to first understand if these health workers were to enter a question into the chatbot, exactly what would that question look like? What sort of questions are they getting from pregnant women in the field? Initially, when we just asked them, oh, what is a question you would enter into a chatbot like this? We got a lot of confusion from them because this is not a type of system they were used to. So then we had a discussion and came up with this qualitative method called a pile sorting exercise. And then we did a focus group discussion. So within a pile sorting exercise, you can see on the left, these healthcare workers are given a lot of questions on a piece of paper. And these questions are translated in their language. And what we ask them to do is separate them into 3 piles. Questions that they get asked very often and are important to them, questions that are somewhat important to them and they get asked sometimes, and there's questions that they totally might not ever get in the field and are not relevant to them. So that helped us focus our chatbot. And you can see there's 3 chairs here, and the ASHA workers are separating out the questions into different piles. And here's pictures of the pile. So then we actually understood these are the questions that are really relevant to them. This is how they would want to use the chatbot. And then we sort of did a bit of content analysis here and tried to look at all of these questions and understand what type of questions do these ASHAs need help with that are within their scope. Because bear in mind, these are health workers educated up to grade 10. So there might be questions that are too complex for them. But thankfully, there were questions that were very much sort of education-based, like why do pregnant women get anemia? I thought, okay, well, that's a good question. And a medical doctor might not have 20, 30 minutes to explain this. Or things like what food should a vegetarian woman with anemia eat during pregnancy? So these are definitely questions that we could help them address. So then we tried to get to know these healthcare workers and went, a little bit ahead in this process of human-centered design. We conducted these empathy mapping workshops where we tried to understand just the general pain points these health workers have when they're using technology. They already were using the smart health pregnancy system. So we asked them, like, how do you feel about this? What goes through your mind? What do you say? What are your pain points? We explained to them what artificial intelligence is as well, and tried to understand how much are they using technology in their existing work. So do they use WhatsApp? Do they have a computer at home? Who are the users? So that was very important for us to get to know them. We went through a journey mapping exercise where we said, look, please tell us, what does your entire week look like? We are interested in you. We want to get to know you. What time do you wake up? Do you use WhatsApp? Do you use any technology? Do you use TV? Do you use computer? And we said, anytime you're using any technology, please just put this in your weekly schedule and show us how you use it. And this was really informative for us to do right at the beginning. We also asked them if they are using WhatsApp, because we realized that everyone in our group was using WhatsApp. We asked them, how are you using it? If you had to enter a question. And at this stage, remember, we were trying to make a chatbot that was going to be text-based. We realized that these ASHA workers do not know how to type. They do not type in their language. So our original assumption went out the window because they were dictating their questions. And that's when we introduced an additional voice to text layer where we changed what we had planned. We did a little bit of a pivot because these ASHAs wanted to enter their questions through voice. In the end, we communicated what we did through these personas. So within our group, we had two specific personas. One was the sort of the tech savvy Asha, and one was the tech navigator. So there were Ashas who were perhaps not super comfortable with technology, but they navigated it and they still used WhatsApp every day. They still all own phones. So we didn't have anybody who absolutely never used technology, which was quite helpful for us. Then we went through a clinical validation process with a team of experts. We created a clinical validation portal where every doctor could sort of have a login. And then what we did was we took the questions we got from the ASHAs, we generated a response, and these clinicians rated each response on the basis of accuracy, completeness, appropriateness, and if they thought there was any bias. We went through different kinds of bias that the chatbot could potentially have, including gender bias, which was an important one. There's one particular one where we had a lot of discussion, which was around stereotyping women's roles. We understood that there was no consensus within the group as to whether this response here would be considered biased, that after pregnancy, a woman should focus on household work. One clinician said, I don't know if it's biased because we give this advice, and others said maybe it's not. And eventually they came to a consensus and said, actually, this particular response here, that a woman should be doing household work after her delivery, it is a biased response. So it was great that we actually had to, again, build from the ground up what is considered bias within their culture. We're not bringing a Western perspective to what we think is biased for them. And in the end, in the clinical validation, the results were really good because we've used retrieval augmented generation. The responses were very accurate. So a 3-point rating meant completely accurate, and across the board, the responses were accurate. What was missing was perhaps the completeness, which we considered later. We also got some qualitative feedback from clinicians, and we ended up adjusting some of the chatbot's guardrails. So here you'll see some example questions that the clinicians entered about perhaps household violence, and the chatbot wasn't at the level where we would feel it was safe. So on the back end pipeline, we put in this area of sensitive topics. Specifically if they're asking questions about gender of the baby, family disputes, the large language model would not respond to them. Then we went through a little bit of super user testing and asked these ASHA workers to tell us, did they think the answer was correct? Was the answer useful for them? And, for every response they gave us a few, they had to answer all of these 11 questions for every chatbot response. So this itself was an intensive exercise. And in the end, the first round, so I've got a couple of rounds here. The first round of results, we felt that the chatbot, wasn't where it needed to be. So we added more guidelines, we made some adjustments, we sort of listened to the Ashas for what they wanted, the length of response, whether they wanted the clarity to be improved, the perceived accuracy. And in the second round, it did improve. So where we're at right now is after we did this, we actually did a video observation study. We decided to look at human computer interaction. And one way that's very common at looking at this is through videos. So we took these super user ashas, put them in a group, explained what the limitations of AI are, and then we created videos of these ashas actually interacting with the chatbot and started observing where the real world issues are coming from so we could have it in the wild study. So this is work that we're still analyzing at this stage. So hopefully this gives you an overview of the entire project. I know I've gone through it really quickly, but I wanted to give you an introduction. So I will introduce you to the team. So these are the Oxford supervisors working on this project. This is the Smart Health Pregnancy Team, the PIs, Professor Jane Hurst, as you know. So when Jane comes, she can probably give you a little bit more detail. Today was an overview. And then this is our entire team here. So our team spans across 3 continents. We're based in Australia, we're based in India and the UK. We're affiliated with the University of Oxford, and we've got the George Institute for Global Health as collaborators. So we're a multidisciplinary team working all over the world very hard on this. And then acknowledging the frontline health workers who've been very supportive in this project. Thank you.
Thank you very much for this really interesting talk. I'll hand over to Kristen to introduce our second speaker, and then we'll have questions at the end. Thanks.
Thanks so much. Yeah, that's a fantastic talk. I'm happy to introduce our next speaker. So our next speaker is George Partridge, who is the portfolio manager of women's health at Kisika Research, which is an industry events company and market analyst advisor. George's primary role is collating the latest developments across the verticals of healthcare and life sciences to inform the strategy and top industry trends shared at Women's Health Innovation Summit, the world's largest business development event in women's health. And I actually was at that a few weeks ago, and it's a fantastic event. And George did an amazing job. So really excited to see, this presentation.
Thank you so much, Kristen, and thanks so much for the kind words. I'm glad that you enjoyed the summit this year. So I guess before I kick things off, I know that a lot of people here are kind of from the academic world, so I'm coming at this from an angle on I guess what we are seeing today happening in the healthcare ecosystem itself, what is happening in the world of startups, investment, and adoption of new technologies. In my role, I kind of work with everyone and anyone who touches this. So I kind of have a bird's eye view of seeing how women's health is evolving today. Um, so I think kind of to begin with a breakdown of what happened at Women's Health Innovation Summit this year, we hit over 800 attendees, which is the biggest that we have ever been. 1,800 connections, 500 one-to-one meetings. And you can kind of see a little bit from our audience breakdown here of what that looks like. So primarily we see startups as our primary audience. The women's health industry is super abundant in new startups. A lot of them are very early stage. So they've kind of been, often academics who have had some sort of discovery and decided to take that forward. But a lot of them are still, trying desperately to raise funds. Women's health sees disproportionately less funding than other areas of healthcare. And another challenge that we face is that many of our innovators are female founded, and there are a lot of barriers to female founded companies receiving investment. Less than 2% of all capital goes to female only founded businesses. So there is a whole angle to the event, which is also focused on the justice of female entrepreneurship. And you can see that we have kind of presence from the wider ecosystem. Only 2% large women's health companies, but that's a reflection of the fact that there aren't many large women's health companies out there still. And a big kind of focus for us has been getting more payers into the room and healthcare providers, because ultimately these decision makers are going to decide to bring in women's health solutions and actually bring access to them to the women that need them. So here you can see this is just a very small portion of the sorts of companies that attend our event. We do work closely with some academic groups as well, but a lot of it is kind of in the world of tech, in the world of pharma, and medical devices too. So these were kind of like the top key takeaways from the event this year. So there is a real focus on payers at the moment. For context, healthcare costs have risen 9%, are expected to rise 9% in the US next year. Thank you, Trump. And that means that we need to be even more vocal about making the case for incorporating women's health, but really clearly showing how this influences costs. Another big focus of the event was cardiovascular, brain health, and particularly autoimmune disease. So now that there is a lot of disaggregation of gender data, we're actually able to clearly show at what points in the patient um, journey women are maybe disproportionately impacted, opportunities to intervene early, and also what percentages of women are taking up intensive care beds, for example. And that has helped make a shift towards health systems actually deploying some female-specific strategies in these areas. Another area was healthcare from home, which I'm going to get to in a lot more detail in a little bit. The investment landscape really kind of was leaning into like ROI platforms. So really leaning into showing data that goes beyond just we can show that there are clinical outcomes that have been driven by our platform. There's a lot of other data sources that really need to be collected now, like adherence data, for example, to make the case for women's health. And then I think AI was a really big shining point for the event this year, but more that now everybody is calling themselves an AI company. How do you actually showcase that what you're doing is different and new and innovative? So I just kind of wanted to start with like a high level overview of the different sort of business models that exist in healthcare. So the first one is employer business models. So this is where you will kind of be incorporated into HR benefits for their employees. But the disadvantage of this is that you're only going to get your solution in front of high earning individuals and in typically large corporate companies. And when you look at the burden of things, for example, in the US, 50% of new births are in Medicaid populations, you're not actually necessarily getting your solution into the women who need it the most. The second is the kind of direct to consumer model. So I'm sure we're all aware of like the cycle tracking apps and whatnot. So they were really hot at the start of 2020. There was a lot of a focus on like personalization of care, which has grown. But the issue with D2C models is that they're not necessarily as scalable, and that the real revenue driver here is going to be what you actually do with that data. So how you can use it in partnerships or use it for healthcare providers, which requires a lot of regulatory considerations. And there is a big question mark around how these apps are actually maintaining data privacy at the moment. And then the final one, which is actually getting your product integrated into an insurance covered model. So that would be being rolled out in the NHS, for example, here in the UK, or private insurers like Bupa in the UK, or you have, Elevance, United Healthcare in the US. A lot of companies focus on the US to be the first market that they roll out in because it's the most lucrative, it's the most biggest opportunity for profit. But the problem is that payers are very difficult. They have a very bad reputation, and the payers that attend Women's Health Innovation Summit are the people in those seats who are making the case for women's health. But in this time with health costs rising, women's health is at risk of being one of the first sort of areas which is kind of cut out of these plans if it's not going to clearly be demonstrated to stop like life-threatening serious health conditions. So whilst we expect areas like pregnancy for like maternal health to still see interest, areas like menopause, which has been such a hype, might be at risk of being dropped from these plans. And the other thing to mention here is that fertility, especially in the US, has always been this kind of private healthcare sector, but it's actually being moved more and more into typical healthcare insurance, which is kind of broadening the access of fertility for years to come. This is just, I realize there is a lot of text here and I don't just want to talk at you all. But essentially women's health investment has grown kind of monumentally. So 2024 was actually the biggest fundraising year ever for women's health. 2025, I think it's TBC. There is a lot of non-dilutive strip backs. Women's health has been affected in some ways by the DEI crackdown. But the good thing to see is that the number of late stage companies is growing. And that's good because the more late stage companies you have in your market or sector is really what draws in those bigger decision makers, either from a private equity world or from a health insurance kind of company world as well. It's seen as a growing market opportunity, and that's how we need to present women's health. Just a little bit here about how consolidation affects the industry. So as you saw at the start, the startups make up such a broad proportion of the audience, but we want to see more consolidation because the more that you can kind of develop end-to-end companies, again, that's what makes the industry look good to those external factors. And it also kind of connects the patient journey a little bit more because rather than going to see one service provider for preconceptive care and then one during your pregnancy and then one postpartum, it's so much more effective to just streamline that and have all of this encompassed into one. That being said, acquisitions were still highest in 2021, so we're still trying to get back to this point. And you'll see a lot here is in the med device and pharma space, which unfortunately has kind of dropped off a little bit in women's health as of recent years. So this was kind of the kind of main themes that came out of the event in terms of the investment landscape. So a lot of early stage investors for new startups, so maybe 2-3 years after you've decided to start your own company, is really focused on conditions that disproportionately and differently impact women at the moment. So cardiovascular, mental, neurodegenerative are kind of the top highlights right now. And that's because we're expecting to see a growing shift towards the actual health systems in these areas applying more of a women's focus and specific strategy, given a lot of the research actually that has come out on estrogen's properties and how women's reproductive health is intrinsically connected to these areas. Overall, right now, it's a very difficult fundraising environment. So later stage companies, there hasn't been much later stage investment. That's something that we definitely are working towards next year, is getting more of those later stage investors to the summit and into our network. But the areas that are kind of growing is maternal health, as I've kind of mentioned, this expansion. So if you're able to grow your maternal health solutions so that you're providing postpartum or preconceptive care, or if you're able to integrate into a portfolio to give them a new type of women's health offering to be that add-on to expand that care. That's also interesting. And then AI just overall was a massive buzz, but under the consideration that we have seen massive growth of AI and digital health across all of healthcare and a lot of early and quick adoption of it. But we need to be aware of the fact that there are data gaps in women's health and that we need to make sure that that the data that this AI model is trained on is really good women's health data. Otherwise, it's not going to work effectively. So here are a few other kind of points from the event. So data capture and at-home care was a massive focus this year. So we're seeing more and more kind of direct telehealth that's being used for kind of contraception, menopause, these conditions where you can kind of have that consultation one-on-one and then potentially mail them interventions for it as well. We're seeing AI diagnostics and non-invasive screening technologies. So this is kind of often biomarker driven, and the idea is to improve early detection, which is going to mitigate healthcare costs and improve outcomes. One of the other areas was the kind of focus on global access and equity. So kind of the stark difference between what other countries around the world, particularly like Africa, parts of Asia, are really not even getting the basics in women's health still. So kind of things like contraception, menstrual health, low-cost models are going to be the thing that allows you expansion here. And then the kind of growing focus on midlife and menopause care. I think we're at a point where we're past like bikini medicine now, and that, you know, not all women give birth, but all women who get to a certain age are going to go through menopause. So the ability to like have your data at your fingertips through like digital health apps, wearables, and more of like nutrition and wellness is kind of coming in here. And then one of the last areas to mention is endometriosis, because it is one the higher prevalence kind of chronic reproductive health conditions. And it's very clear the correlations between fertility and maternal health risks. So it's kind of sad, but the other kind of chronic, really underserved reproductive health conditions have kind of not been seen in the limelight. Like the early investors are not focused there, and the late stage companies are not interested in them that much at the moment. That being said, like we are expecting to see endometriosis grow massively, but it's going to require first diagnostics to come in, and then devices come in, and then therapeutic approvals in that order, because it is still lacking that framework. But we know when we get that framework there, so many women have this condition and are so desperate for solutions. So then I just kind of wanted to talk here a little bit about digital health enablement. So providers and just in general, like kind of what's happening in the provider landscape. So healthcare providers, as I said, there's like two kind of main streams where digital health is being prescribed. It's for that kind of chronic health problems that, you know, what all women have, so like menstrual health, contraception, menopause, and just moving all of that healthcare virtual. And this is kind of switched with the ability for AI diagnostics and at-home monitoring to come into oncology and maternal health, where, you know, there are significant complications if this is not caught early, and like these big cost drivers essentially, and serious poor health outcomes that can be mitigated. The providers really talked about how like they need more adherence data. Their priority is going to be patient safety and product integrity. So they want to know that your data is good, and they want to see that your product is going to be used by patients and that the patients are going to use it appropriately. Discussions really centered around the burnout of OBGYNs, the fact that in the US, the payment is lower for them as well, and that this can be alleviated by AI tools, software, and devices. But they really kind of cautioned this with the fact that admin burden is such an issue for doctors, and that these need to not separate out doctors and take up more of their time, but actually integrate and be used effectively. And then just a side note on what's happening here in robotics. There's a lot of training going on in the US of like new robotics that can be used in gynecological surgeries. And AI-driven robotics is also seeing application fertility for like gamete and embryo selection, and more in the lab, essentially. That's supposed to become more widespread over the next 5 years. So we might see greater fertility success overall, which is in turn going to drive down costs and make it more accessible, with the kind of con here being that that this robotics technology in a way is going to replace the embryologist. So maybe a change of like job roles within the fertility ecosystem. So new healthcare transformations that were kind of mentioned as well. So the kind of changing role of the OBGYN being impacted by research on estrogen and other hormones, how these impact other facets of care. But we still see that most endocrinologists who are these hormone experts are going into fertility more and more. There is some that is kind of growing in the menopause area, but in general, like people are going into fertility because it's what's going to give them the most, like the highest salary, the best flexibility with their job hours. They're aware of like how difficult it is in the hospitals and kind of more of that OBGYN role. So this is what has kind of been shifting in the workforce. There was kind of like this focus on women's health specific strategies that I've mentioned, but one that was really interesting was how Northwell Health are like using mammograms to for cardiovascular risk scoring, because it can detect arterial calcification more effectively than lifestyle factors. So I expect to see this sort of blending of women's health and kind of like overcoming the silos with surrounding healthcare areas. And then in the US, fertility just in general is becoming more mainstream healthcare and less exclusive fertility clinics. And the OBGYNs here in the UK, like OBGYNs can do everything. In the US, it's more siloed. You have different types of OBGYNs and endocrinologists, but now they're kind of all being trained to do a number of different reproductive health techniques. So kind of in summary, what is happening today? The women's health industry has survived the DEI crackdown. Government funding has been stripped, but it's greatly impacting research the most. So we need to see more of these nonprofit institutions like the Gates Foundation bringing their dollars forward, because research is still the heartbeat of everything that goes on in industry. It might take a long time to get there, but this new research is all being used to help the solutions that are in the market right now see greater distribution, see greater uptake. So that's where the main issue is with that crackdown. Investors did highlight the vast number of copycat startups in the industry, and they were basically just saying, we cannot have another app. Like if you're thinking of developing your own app, really double check that that app is already not out there and doesn't exist. And they kind of talked about how the pitching of women's health has changed. So don't start with your personal or founder story, especially to health insurance companies, but also investors now. And that in some ways, it's actually adding clarity to the women's health industry, because there is less of this focus on social justice, and all companies are positioning themselves as a disease area that is potentially seen as like more serious, which is just some of the things that the stigmas that the women's health industry faces, and still being seen as niche by surrounding factors. And then I just wanted to have some points for you guys if you are attending any events of what my advice would be. So reaching out to the people you want to meet in advance is so critical. Make sure that you actually get to see them, especially if it's a very busy event. Make the most of the organic networking receptions. Sometimes you meet someone who you didn't even know was attending or who they were, and that leads to the most exciting, surprising opportunities. Definitely follow up with people as soon as you're out of the event. So those next 2 to 3 days are going to be critical. And I like to wear something memorable. I usually wear a very fabulous purple blazer, and that is able to make an impression on people. And if cost is an issue for you, please reach out to the event organizers, especially the producer, which would be the person in my seat, for example, because we're the ones that are able to be accommodating on things like price point or travel. So in summary, women's health is seeing interest from the larger decision-making powers at B, but there is still bigger focus, especially from later stage adoption, that is on fertility and maternal health, with a bit of a growing focus on menopause. So we're seeing that the chronic reproductive health is still being left behind. And it's this awful chicken and an egg scenario where people are hesitant to invest because they don't see the existing industry framework, but then there are no solutions in the industry, it actually being adopted into industry, because no one has invested. So it's a bit of a bit of a sad scenario. AI and digital health is seeing, large investment adoption, but really just that focus on data and different types of data sources, not just your clinical data, is going to be important. A movement to more holistic healthcare, so integrating with surrounding areas of that disproportionately impact women, but then also the consumer wellness industry blending with true medical healthcare. I think we've seen a lot of that off the back of like GLP-1s, for example, where you take your GLP-1 and you're on a fitness plan and a nutrition plan. The same sort of thing can be applied to menopause, and actually menopause itself can be brought into GLP-1s and more lifestyle health. And then, yeah, expect to see a bigger spotlight on these conditions that disproportionately and differently impact women. That was everything. I know we're going to questions now, but thanks so much for having me here today to speak. And I'm happy to also speak with any of you about the world of industry later.
Thank you so much, George. It's a fantastic talk, and I think super informative to everybody on the call that might not be as familiar with the industry trends. So thank you so much for giving that summary. And I do honestly recommend going to that event as well. It's fantastic. So I'll turn it over to Annalisa for the question session.
Thank you. Thanks, Christian. Thank you, George and Ankita, for the presentation. I think you both gave a different perspective, but at the same time, relevant from the industrial and then the research side. So that's really important. Thank you. And I also like your point, George, about making sure that we to make the most out of networking. And hopefully this meeting here and this type of webinar are really helping people connecting across different parts of the world. So that's really important. Thank you. I'll open the floor for questions. So put your questions in the chat. And in the meantime, I'll start with one question. You can also raise your hand if you prefer to ask questions yourself. The main question is, my first question is a bit general, but it's about the main challenge that you see in accessing those funding available in women's health area, because we've seen that the area is not very well represented in the funding scheme, and this is of course in the UK, but as you mentioned, George, also in the US. What do you think is the main challenges? I mean, you can give different perspective from the research side, but also from the industry side. I'll let you, Ankita, start. That's okay with you?
Yeah, so from the research perspective, I can share something that was personal to us at the moment. So one of our first challenges when it came to this particular project was just getting the ethics approval. So while we, had something running, not many people understood that we're trying to apply AI to women's health and this is going to be safe, and many people didn't see the value. So similar to what George said, so in our initial first ethics application, we actually didn't even were asked to remove the word AI itself. So I think there is this sort of almost this the stereotype or this idea that women's health and AI and innovation, these things don't go hand in hand. And that is something that we had to personally face. But yeah, I think from George's perspective, you would be able to give the wider overview.
Yeah, I think the thing to know is like who you are pitching to and how you then tailor that pitch, at least on the corporate side of things. So if it is a nonprofit, like really leaning into the mission of women's health, for example, if it's non-dilutive, if it's specifically from an equity perspective to advance women's health. But then if you're speaking to the wider kind of VC ecosystem, I would really think about how you're tying it back to costs and revenue the whole time of the talk, whilst obviously still pointing out the clinical outcomes that you're doing. I think the second thing is kind of like making sure you have a really robust board. So like, other kind of like leading researchers being involved in the project is great, but then other kind of tech companies who are maybe further ahead, maybe they've worked on something similar to you, is a great person to kind of reach out to. And then anyone who has kind of worked, say, if you're in the diagnostics, you're probably going to want to reach out to someone who has taken a diagnostic forward to market and kind of understanding what that pathway looked like and bringing that expertise into your business early. And then just really like having your unique value proposition like really, really nailed down. So what is it that you've done that nobody else has done? And why does that mean that by investing and taking your product forward, that there's actually going to be a significant change in the ecosystem?
It seems to me that the key message is then making sure that we are working together, essentially, because yes, an AI person will never be able to do anything without the help from clinician, but also from the support from industry. So I think that's probably the key take-home message. I can see that Bianca, you got your hands up. You got a question or follow-up?
Yes, I guess it's a nice follow-up from what you just said. It's a question for Ankita actually, and it's about your collaboration with the Asha, is it called? I forgot the name. Yeah. Because you presented really extensive user research with them, which is quite impressive. But I assume it's quite time-consuming investment from them. So I was wondering, how did you manage to recruit them? How did you keep the engagement? Like these can be quite challenging. So yeah, I just wanted to ask if you could explain a bit more. I was also interested in whether you had compensated them financially for their time and for their input, because I'm assuming the research you've done with them must have taken several days at least. So yeah.
That's a great question, Bianca. And I think that I think I need to sort of clarify our background a little bit, because our intention was not really to create the next best tech innovation and then pitch it to a VC. So this goes with, the background of the George Institute of Global Health. This is essentially their strength, is this community health worker integration, working with them. So they've spent years and years developing these relationships, and our focus was really on building this this evidence base, doing the research. So then later, if a tech company wants to come in and collaborate and build a better system, they've already got the groundwork laid out for them. So, for us, we're firstly a research organization for global health. We're not a tech organization, but in saying that, there can definitely be a huge collaboration there. In terms of working with the ASHA workers, the George Institute for Global Health, like, they've had years and years of relationship with medical colleges, for instance, that already exist there. And these medical colleges have community health doctors who've known these ASHAs for years. So there was an entire system in place before we brought in Smart Health GPT. These existing relationships were important. And these ASHAs were already in the Smart Health Pregnancy trial to begin with. So it was easy to integrate this research because they were already sort of doing the work for Smart Health Pregnancy. We just added a little icon and said this is a little bit more. But in terms of doing the additional user research, and yes, of course, we had to compensate the ASHA workers for their time. That is, ethically, we have to do that. We have to respect their time. And they were very, very happy to actually participate in this sense because of those existing relationships. They were talking to field supervisors and doctors that they had already known for years, and we were taking an interest in them from a very different perspective. In this case, there wasn't any pressure on them to tell us this product works, yes or no, because that social desirability bias can be there when you're talking to users. They can just give you the information you need. We actually didn't tell them, tell us what tell us whether you like this or not. We just said, tell us what you need and tell us about your lives, which was a very, very different perspective. So we wanted to validate the problem. And coming in from from the market side, I think George might be able to tell more. A lot of products fail. I think it's 42% fail because there's no real market need for them. So if somebody were to come to us, we can actually validate that market need from a global health perspective. We've done that groundwork. And then when it comes to the tech, there might be bigger, better companies that can come and take over.
Thank you. That was very interesting.
Thank you. I can see there is another question from Martin. Please go ahead.
Thank you. I wanted to say thank you to both of you. Very, very interesting talks. I have a question for George. I'm curious if you've seen any differences in the gender of the founders in this field and how they're received, like by the investors, by other founders, by other leaders. Yeah, I'm curious about your thoughts on that.
Yeah, so I think that there is almost like two communities within women's health right now. Ones which are very much like, we don't care about the gender of the founders. Like, a win for women's health is a win for women's health, whether it's being created by a male C-suite or not. And then there is a community which, will primarily or only invest in female-founded companies. I think that there was definitely more of an opportunity from like a female entrepreneurship, leadership, equity angle prior to 2025, which could have given you access to potential other funds as a woman. I think that, like, personally, it's so important to have female leadership in the perspective of women's health. I think that there is just a different nuance that comes to it. And there is nothing more like, there was one or two male founders, particularly, who shall not be named, who were kind of walking around the floor talking about how hard it is to get funding as a man in women's health, and it's kind of like, read the room. But I would say that there is kind of like, right now, the overall state would be that there is a preference to have female leadership in your company, but it's less of like a requirement necessarily to receive funding.
Interesting. Thank you.
Thank you, George. We have time for one last question. I think that Kristen.
Sure. My question was for Ankita about, so you talked a little bit about the AI tool that you developed, which was based really in sort of like a geographical region with guidelines from that area and kind of comparing that to ChatGPT. So I was kind of wondering if you could expand a little bit on that and talk about maybe this kind of idea of creating like an intentional AI that's really based in the community that you're working with, rather than these sort of huge large language models that kind of scrape data from everywhere and kind of give you this kind of Frankenstein answer from a lot of different places.
Thank you, Kristen. That's a really, really important point that you bring up. So yes, we could have just used ChatGPT as it is, and if this was maybe a technology company, that would have happened. The other thing that could have happened, which is quite common in the AI startup world, is using synthetic data. And that would have been cheaper if we just imagined what questions these ashas would get based on the guidelines. I think if we had taken a tech first perspective, that would be the case. But again, like I said, we are a research organization focusing on global women's health and technology. So ultimately, if you look historically, we know through innovation, women's health, how things have developed is women's voices are often not represented. And we were very, very conscious of that, is that, yes, it's going to be harder, it's going to take more time. But rather than having a large model that doesn't represent the voices and concerns of women on the ground, we want to start with their exact needs, their exact questions, and even understanding bias from their own perspective. So we had to even thoughtfully think about guardrails. So if you were to just slap on a big model on there, it might not understand what safety concerns are relevant to that specific region. So to give you an example, one of the questions that would come up in the field is about fertility, where women would inquire, I've been trying to have a baby for so many months, but I'm not able to get pregnant. When we did what it was called a consequence scanning exercise, we spoke to different clinicians and health workers and said, what could potentially go wrong for the woman if the AI gave the wrong answer? And for this context, it was something we didn't imagine. If the AI even made subtle suggestions, saying, oh, your period is late, and maybe this could mean there's issues with your fertility, without any questions asked within the family, she could get a divorce. There could be violence against the woman. There could be potentially she could lose her life. She could be shamed within their community. We often think about AI as just being accurate, and traditional benchmarks, when you look at ChatGPT or Gemini or anything, those benchmarks are not looking at social consequences. Whereas creating this niche, sort of very small GPT model in a very slow, intentional way meant that probably, for the first time, we were thinking about women holistically and not just saying these benchmarks relate to accuracy. It was about their mental health, their social health, and their overall physical health.
Thank you, Ankita. Yeah, and that raises another important point that AI, of course, is an amazing tool, but I think you always need the supervision of specialists. So we'll just need to go hand in hand. So I think that's a really nice point to close our meeting with. So I'd like to thank you both again, George and Ankita, to finding the time to share your amazing work with us and with our community today. I'd like to remind everyone about our next meeting, which will be on the 27th of January, 12 o'clock, and we will post, as always, everything on LinkedIn. So thanks again for joining us, and we'll see you. Have a nice Christmas. Yeah, I think we can say that, and we will see you next year. Thanks again. Bye.